You want to start?
Hello, everybody. This is now, we are going to start with the live question and answers session with case studies. And I have with me Professors Mike Satek from South Africa, Raluca Metitlo from Romania, and Professor Ziti Lee from Australia. We will have some case studies and live question and answer sessions. So let's start.
All right, so I understand there's no audio, so let me see if I can redo that real quick.
.4 gigabecquerels per cycle lost 14.8 gigabecquerels of 177 lutetium marked with a new molecule in patient with castration-resistant prostate cancer. 177 lutetium IPSMA is a new molecule developed at the National Institute for Nuclear Research with these characteristics. We treat 17 patients with metastatic castration-resistant prostate cancer to symptomatic and progressive, previously treated with second-generation anti-androgens, taxane-based chemotherapy or 222 radio, and with metastatic lesions with 68 gallium PSMA uptake. The biochemical behavior after 2 cycles of 177 lutetium IPSMA was analyzed 3 weeks after the second cycle. We administrate 7.4 gigabecquerels per cycle every 6 to 8 weeks. Hello, I will present you the historical evaluation of straight 7.
Partner associations as well.
Sorry.
Hello, I will present you the historical evaluation. Hello, I will present you.
Fortunately, I'm having problems replaying the entire case, so I may have to just go through and show you the results here. I'll return it to you while I see what happened to my screen share. Lisa, are you there?
Yes, yes.
I wasn't able to play the full sound of that, but were you able to see the case? Do you want me to put it back on the screen?
We did see the case. It was a case of patient evaluation of the biochemical response post 14.8 gigabecquerel of 177 lutetium marked with a new molecule IPSMA in patients with castration-resistant prostate cancer. And the conclusion was it's an efficient and safe therapeutic alternative for the management of patients with castration-resistant prostate cancer. And you need to administer at least 2 doses, which allows a reduction of PSA values by more than 50%. And more prospective studies are needed to evaluate the mean progression-free survival. I must add that we have, yes, so this is the sum of this, the conclusion of this presentation. And we have these cases were from several countries, and we are pleased at the very high level of standards of entry received. And after this session, we will present the best poster.
Do you want me to present the next case, or do you want to have comments on this?
We need to go to the next one now. And the next one is, let me just read it. Is the treatment response and safety of lutetium-177 PSMA 617 radioligand therapy in metastatic castration-resistant prostate cancer.
I am Dr. Gerardo dos Santos from Montevideo, Uruguay. I want to share with you the results of this research concerning prostate cancer. Lutetium is an increasingly used new radioligand therapy in metastatic castration-resistant prostate cancer patients. So the aim of this study was to evaluate treatment response and safety in these patients. 17 patients underwent lutetium therapy. The mean age was 67.3 years and the median PSA level was 100. 68 gallium PSMA PET-CT was performed in all patients 1 week prior therapy and at the end of treatment. All patients received 1 to 5 doses of lutetium every 6 or 8 weeks. We evaluate clinical response, therapy response, adverse events, and dosimetry. PSMA-avid metastatic lesions were seen in the following seats: bone, all patients, lymph node, liver, lung, and adrenal gland metastases in 11, 2, 2, and 1 patients respectively. 12 patients, that is 70%, saw pain relief and reduction in the use of analgesics. 5 patients show biochemical response, 3 patients stable disease, and 7 patients progressive disease. We documented serostomia, nausea, fatigue, and thrombocytopenia in 2, 3, 5, and 2 patients respectively. There was no hepatotoxicity nor nephrotoxicity documented. The safety of lutetium for non-target tissues was confirmed, showing mean absorbed dose below the recommended ones in critical organs. 68 gallium PSMA PET-CT images show disease progression in 9 patients and partial remission in 5. About images, the lay whole body images show retention of lutetium PSMA in the metastasis with relative rapid. I am Dr. Gerardo dos Santos from and see sequential images in 2 patients after 5 and 4 cycles of therapy respectively. Note the continuing PSA decline and significantly response in gallium PSMA PET images. So, as a conclusion, radioligand therapy is a safe and well-tolerated therapeutic option for patients with metastatic castration-resistant prostate cancer. Thank you.
Good day. My name is Trisha Govender, and I represent Nuclear Medicine Imaging and Therapy Centers in South Africa. My abstract for today is based on the benefit of early verse delayed dual-point imaging in neuroendocrine tumors of the abdomen using gallium-68 DOTA-NOC PET-CT. I present to you a 69-year-old female. She presented with a mass of mixed density in the right hemipelvis extending into the right lower abdomen. This was seen on the CT imaging. On presentation, she presented with elevated tumor markers. Her chromogranin A level was 156.1. A biopsy was recommended, and this confirmed a well-differentiated neuroendocrine tumor, A grade 1. Presenting the images on figure 1. This was the early images. There is activity seen in the gastric wall. On figure 2, delayed images were done, and this is showing total washout of activity indicating a gastritis. This was confirmed on a gastroscopy. Thank you.
Respected Chairperson of the poster session of 15th ICRT, my nuclear medicine colleagues from around the world, greetings from Bangladesh. I am Professor Zina Jabin with the poster titled Sternal Bone Metastasis from Differentiated Thyroid Carcinoma, a Single Institutional Experience.
In the Military Medical Academy in Sofia, and head of
I shared the
Department of
experience
Nuclear
with 9
Medicine in
female
Sofia
differentiated
Cancer
thyroid
Center.
cancer patients
She has
of
been a
55
member
to
of
60
WARN
years who
since
were histologically proven as
2005,
follicular thyroid
and
cancer
she is
or
in the
follicular variant of
editorial board
papillary
of the
thyroid
Journal of
cancer.
World Journal of
They
Nuclear Medicine.
presented with firm to hard
And
bony
I am
swellings in
really
the
very
anterior
happy to
chest,
introduce her
either
to
at
this
first
meeting.
visit to us before or after total
The second
thyroidectomy or
speaker will be
downstaged
Melina
after a
Benedico.
fair gap of thyroidectomy and
Her talk
radioiodine
will be
ablation,
about women
presented with a
nuclear,
new lesion.
over 25
Now,
years
the
of
treatment chosen
promoting
by the multidisciplinary team consisted of external beam radiotherapy to reduce the size of the lesion first, and then sternotomy or manubrial excision or excision of the lesion as much as possible, followed by radioiodine ablation therapy and follow-up. On an average, patients were followed up for about 52 months and multiple ablations were needed in most of the patients. This 60-year-old follicular thyroid cancer patient developed this lesion 3 years after total thyroidectomy without radioiodine ablation. She said she wasn't advised. Then, high-resolution ultrasound revealed a huge solid mass lesion on manubrium, which showed intense iodine 131 uptake in whole body scan and a positive PET-CT, and also there were metastatic lymph nodes in the neck. So, a team of otolaryngology and thoracic surgeons jointly operated this patient in a single surgery and excised the manubrium and covered it with a proline mesh, excised the neck nodes, and then sent to us again. So far, 3 radioiodine ablation were given to this patient, and she showed very good response. The key message is the management of differentiation. Respected Chairperson, very good response. The key message is the management of differentiated thyroid cancer with external metastases can be extremely challenging, and the multidisciplinary team approach appears to be the strategic factor in a tertiary hospital to achieve a good prognosis. Thank you.
Hi, everyone. I'm just going to give a quick presentation about the use of ventilation perfusion lung scan in a pregnant lady that we performed during the COVID times. As you all know, COVID itself is a hypercoagulable disease, and together with pregnancy, it really made it quite difficult and also important to diagnose the two. And during this time, I know a lot of centers around the world actually had not only a reduction in the referrals, but also declined to do the ventilation part of the VQ scan due to the fear of it being an aerosolized generating procedure and spread of COVID. We used Technigas machines that was deemed and safe to be able to use during the COVID times. And it was in a lady who was 24 weeks pregnant with a close contact of a COVID patient. And she did, in fact, have the changes that was found both on the VQ scan, having mismatches consistent with PE. But in addition, we also did the low-dose CT at the same time, which also showed some COVID-related lung changes in the parenchyma and the lower lobes. So it was a very useful scan for the doctors treating this patient to make sure that the patient was treated for both her COVID illness as well as anticoagulated for her pulmonary embolism, and she did well. Thank you.
Good noon, everyone. I am Dr. Jasmine Firdaus from Bangladesh, working as an assistant professor in National Institute of Nuclear Medicine and Allied Sciences, Bangabandhu Sheikh Mujib Medical Campus, Shahbag, Dhaka. Today, I am presenting a case series, Unusual Sites of Metastasis from Differentiated Thyroid Carcinoma. My poster number is 123. Clinical history. Here I am reporting 4 cases. Among them, 3 were female and 1 was male. The mean age was 62 years. Histopathological report revealed 3 were follicular thyroid carcinoma and 1 was papillary thyroid carcinoma. The metastatic sites were left side of the upper gum, roof of the nasal cavity, including right ethmoidal sinus and right lobe of the liver. The patient with liver metastasis was diagnosed at the time of the patient with liver metastasis at the time of diagnosis by ultrasound imaging. The median interval between the first diagnosis and metastasis of other cases was 5 years. In whole body post-therapy scan findings only liver metastasis showed iodine avidity. All metastatic sites are confirmed by cytopathology report. Gum metastasis was excised, and other two cases refused to do surgery. And thyroglobulin level in all cases were more than 300 nanogram per milliliter without any interference of thyroglobulin antibody. In figure 1, photography showing mass in the left upper gum from follicular thyroid carcinoma. Left upper gum mass as well as neck swelling was developed 1 year interval at the time of large dose scan. In figure 2, MRI showing mass in the roof of the nasal cavity from papillary thyroid carcinoma. The patient was diagnosed in 2006 as papillary thyroid carcinoma without any metastasis. After 13 years later, she developed this mass. In between, she had undergone 3 times revision neck surgery for lymph node metastasis. In figure 3, ultrasound image showing hepatic mass in the patient of follicular thyroid carcinoma, and the CT scan image of same patient showing metastatic mass in right lobe of the liver. And in the left side image showing big metastatic follicular thyroid carcinoma, and this patient had also metastasis to the lymph node and bone. In figure 5, post-therapy whole body scan of patient of follicular thyroid carcinoma showing intense iodine avidity to the metastatic lesion in the liver. Thank you all.
Thank you for the opportunity of discussing these cases. I'd like to present 2 cases where we've used a particular approach to anaplastic thyroid cancer with, so far, very good success. Background is that anaplastic thyroid cancer, as we all know, is a highly aggressive cancer, where up until very recently, our treatment modalities were quite poor. Median survival in a number of series show months of survival rather than years, and we had limited approaches. There has been some recent data on the use of immunotherapy, as well as the use of multi-kinase inhibitors to try and improve the outcomes in these patients, full stop. And these patients often, however, also have PSMA expression. We decided to take a multimodality approach to see if we could improve patient outcome, and I'll discuss the 2 patients. Patient 1 was a 75-year-old male who presented with symptoms of shortness of breath on exertion and neck swelling, full stop. CT revealed a mass in the neck with lymph nodes, together with lung metastases and liver metastases, full stop. In July of 2019, he underwent neck surgery to try and debulk the tumor and prevent future airway compromise, full stop. He was referred to myself, and investigations, including FDG PET and gallium PSMA PET, showed that a number of his lesions were PSMA avid, such as his right proximal humeral lesion and several of his lung metastases, full stop. A combined approach of nivolumab immunotherapy together with actinium PSMA at 100 kilobecquerels per kilogram on a 2-monthly cycle of actinium PSMA was initiated, full stop. He had good response to this combined approach, full stop, due to the development of some chest pain around January of 2020 in the left side of the chest with a persistent and growing mass. Radiotherapy was instituted towards the end of his actinium and nivolumab therapy to the left chest, full stop. He was then commenced on nivatinib as maintenance therapy, full stop. He had significant improvement in symptoms with resolution of his shortness of breath, weight gain, and improvement in overall well-being, full stop. Most recently, he presented with some upper airway, back of throat pain, and further investigations have revealed recurrence in the right tonsillar region and also evidence of new metastases in the right supraclavicular region and mediastinal lymph nodes, full stop. His nivatinib dose has been increased and he's been restarted on. He has recently started further SBRT radiotherapy to the sites of FDG avid disease, full stop. Of note, his new disease does not appear to be PSMA avid, full stop. The next patient is a 67-year-old woman who presented with shortness of breath and insertion, orthopnea, and neck swelling, full stop. Investigations revealed a large mass at the thoracic inlet, full stop. The mass was biopsied and shown to be anaplastic thyroid cancer, full stop. She was not suitable for further therapy because of her extensive disease, and thus her surgery was not initiated, full stop. After discussion, she was commenced on external beam radiotherapy together with nivolumab. Once her radiotherapy was completed, she was commenced on actinium PSMA, which has just recently completed. She's due to start nivatinib therapy. Her symptoms, however, have totally resolved. She's due to have follow-up imaging next week. Thus, we have 2 patients who have had very good response to date with multimodality imaging, guiding us to multimodality therapy. In both cases, PSMA avidity has been shown to be present, and we've used a novel alpha therapy PSMA treatment in combination with external beam radiotherapy, immunotherapy, and followed this with tyrosine kinase inhibitors, full stop. In our first patient who has now relapsed, we are considering
Sorry, I'm returning it to you.
Okay, that's the end of the clinical case reports presentations. Now we are open for question and answer session. Any questions? Does anyone have any questions? Marsha,
do you have any commentary on the cases?
Yeah,
any commentary on? Yeah.
Yeah. So, you know, we saw some really good overall case presentations. I think the really one that is relevant even to the current times is the COVID, and obviously some departments that are not doing VQ scans. So my question would be, sitting in your department, if they are COVID positive, do you all do both the ventilation and the perfusion, or do you all just do the perfusion?
No, we do a full ventilation and perfusion, because as you can see, you can get perfusion defects. So you really need to know if there are mismatches or not. But our staff would actually be in full PPE. So the technologists, and there'll be 2 technologists who do them. So one stays in the room with the patient in full PPE, and the one outside would be the one that you know, does the scanning itself. And also when they do come out for the CT component, then they do step into a corner that is dedicated for donning and doffing of the PPE at the time. So it's full precautions, full COVID precautions when we had to do patients who are either COVID or even suspected COVID. We go through these precautions.
Okay. In terms of dual point imaging or dual time imaging, Mike, I know your team did do a paper a few years back on dual point imaging with FDG. Do you think that's something that would become common with most PET tracers in terms of the target to background, or you think that it's just selected cases that would benefit from dual point imaging, both from FDG as well as from other tumor targeted tracers?
Hi, Miss. I mean, dual tracer imaging. It's an interesting thing for several things.
Yes, and dual tracer. Yes.
Yes. So at that stage, we're trying to see if we could have a way of trying to distinguish some form of pathology one from the other. And of course, when we did the dual, that we couldn't succeed in distinguishing the pathologies, and some malignancies really were not distinguishable from infection. You are referring to our dual tracer, to the delayed imaging of the dual tracer, I suppose.
Yes, yes, one you did with FDG, yes.
Yes. So, of course, in our setup, where tuberculosis is a problem, so that was the intention, to try and distinguish it from malignancy, but we couldn't distinguish it. You would still have to subject the patients to biopsy and unraveling the situation at that situation. However, the other infections, we could really distinguish them from cancers, in the sense that you will obviously have either the retention index being decreased or staying the same in inflammation and infection, whilst it will be more with cancers. So that approach can be useful if you are not suspecting tuberculosis.
Okay. One of the questions that was actually posed to me on LinkedIn when we were posting some of our studies, with warmth in the ICRT, is with FAPI. And I know we didn't go too much into detail with that, but I suppose those who have experienced FAPI can answer this. The fibroblast activation protein is FAPI, and imaging with that. And is that something that would eventually replace FDG? That was the question that was posed.
I suspect we are doing FAPI imaging. It's good. It really has got some place, but surely it won't be intense in some of the lesions where there are mucinous expressions. But it's indeed, there has got a great potential to be a routine imaging as we go on. The thing about FAPI, unlike FDG, at least we do have a theranostic approach, probabilities with it. You'd realize there are at least 3 formats of FAPIs. We do have FAPI that is labeled with F18, with gallium, and with technetium. The technetium one, of course, still under development with at the moment Heidelberg group. But the nice thing about that one is, of course, when you label it, then you can immediately label with rhenium as well. So you've got a theranostic approach, because rhenium and technetium are essentially the same thing in terms of labeling skill. And that will be interesting. But however, the problem is still the biological half-life of FAPI. That is still a problem if you're going to go with rhenium. And then the one that you label with gallium, it's also then automatically labeled with lutetium as well. So that also makes it interesting from that point of view. So those two, the 3 FAPIs that are there with all the imaging isotopes that we commonly use, gallium, F18, and technetium, are really getting more and more utilized as we speak now. There is, I'm told, there will reliably be a big trial on the gallium one, and later on the F18 one. So what we probably have to do as the nuclear medicine community, I think, is to try and work on the biological half-life of FAPI itself, so that we can increase it to make the probabilities of a theranostic approach more and more realistic. So that they will complement each other, to answer in short, in my opinion, but it don't replace it. But I think it will complement each other, because we are looking at different ways of behavior of the cancer. I mean, we're looking at the microenvironment with FAPI, which is obviously, it is obviously 90% expressed in some tumors, and those tumors that might be resistant. But I think the great thing it will be that it might be a theranostic tool, which FDG won't do.
I have a question for Mike, actually, on that note. In terms of the patent and the licensing of FAPI, I mean, obviously FDG is widely available for all countries, large and small. With FAPI, has that actually been licensed now? So it's only going to be, yeah.
Yeah. The company Sophie actually is handling that. Actually, the one that was developed from Heidelberg. I think you are aware that there are various FAPIs. For instance, like there is a group in Germany that is working together with the group in Chile and in India. They are using a different FAPI, and there is patents to that effect that are two separate patents. But the one from Heidelberg is now taken over by FAPI, and that's the one that will probably be the routine available one and widely utilized. So it's FAPI 46 at the moment. It started by being FAPI 4. I think Irene probably will also be knowing and having that information. But FAPI 46 for the gallium 68 is probably going to be the one that will be made available with the patent secured and so on. Then FAPI 74 for F18 will probably follow suit soon as well. The one that is really a little bit very early, it's still the FAPI 34. The one that is for gallium, for technetium, it's still a bit investigational at the Heidelberg team.
Yeah, but they're all under patent.
Yes, they are.
Okay, yeah.
My next question to anyone in the panel is, has anyone used benzamide, which is the melanin-targeted imaging agent and therapeutic agent? It works with I123 for imaging and I131 for therapy. And what are the prospects for future melanoma therapy with benzamide? Anybody?
No, we haven't had that particular experience with benzamide, but obviously it is available, and being melanin related, it's still very experimental, and we'll need to see what its role will actually be, I believe.
Okay, great. I don't have any more questions. Kazar, do you have any more questions from your side?
I was very impressed by the NetLens's talk about actinium PSMA treatment for thyroid metastasis. Are there any studies to that effect, or was this the first time somebody tried it? That's my question. Z, you're part of the world?
No, in fact, I mean, what's interesting about anaplastic is that we actually have 3 patients now who have defied the odds of anaplastic carcinoma. They've gone beyond the 5-year mark, which is almost unheard of. Their genetics are being looked into at the moment. One has recurred, but then again, treated with immunotherapy on its own. So in terms of using PSMA or actinium for treatment, no, we haven't, and there certainly are no trials. They're just anecdotal examples of patients that were put onto it, and the general treatments for anaplastic would include external beam radiotherapy and also a radiosensitizing chemotherapy as well. So from that point on, in fact, for 2 of our patients, we managed to squeeze in a dose of radioiodine beforehand as well, because they had a papillary component on top of the anaplastic that had metastasized to the lungs. I actually told the patient, I'm so sorry, you won't do very well from your anaplastic. You will have a few months to live. She did everything she wanted to do, went skydiving and all that. And then she has come back year after year saying, you told me I only had 6 months to live.
Oh, that's brilliant. You're doing everything in your armamentarium, but we don't know which one worked.
Yes. Well, no, we treated her with the standard treatments. So we actually treated her with the standard external beam and chemotherapy, and the radioiodine was really just to attack the papillary side, or that's what we thought anyway. So yeah.
Okay, any more questions? If not, then we can bring this session to conclusion and give over to Partha. Josh? Masha, any more questions?
No more questions.
Okay, then we will not delay the next session. Thank you very much.
Thank you.
Thank you.